All right, our next presentation is a video entitled Let Them Play, a prospective study of postoperative activity restrictions in children, presented by Rachel Harvey, a medical student from Oakland University William Beaumont on behalf of Beaumont Children's Hospital.
Hello, my name is Rachel Harvey, and I will be presenting Let Them Play, a prospective study of postoperative activity restrictions in children. I have nothing to disclose. Postoperative activity restrictions aim to minimize the risk of surgical complications and prevent stress on the operative site. In the pediatric population, surgeons may restrict school attendance, participation in playground or gym activities, and participation in contact sports or heavy lifting. There is a lack of strong evidence guiding surgeons with regards to postoperative restrictions following routine procedures. While many surgeons give specific postoperative instructions, a recent study discussed the idea of self-directed activity restrictions. The purpose of self-directed activity restrictions is to let the child return to normal school and physical activity when their pain is improving and their parent or guardian feels comfortable advancing their activity. We set out to evaluate whether self-directed activity restrictions were safe, feasible, and associated with quicker time to full activities. We developed a prospective clinical trial where patients and their families were able to choose whether they would follow traditional physician-guided instruction or self-directed activity restrictions. Patients who enrolled in the physician-directed group were instructed to restrict full activity for 2 weeks following their procedure. Patients that enrolled in the experimental self-directed activity restrictions group were instructed to return to full activity when their pain had improved, they were no longer taking pain medication, and their parent or guardian felt comfortable advancing their activity. We hypothesize that children who follow self-directed activity restrictions will return to full activity sooner, report greater levels of patient and caregiver satisfaction, and experience no difference in postoperative complications. Patients between the ages of 2 and 13 who presented to Beaumont Royal Oak or Troy for a routine inguinal hernia repair were eligible for participation. Patients between the ages of 0 and 17 who presented for a laparoscopic appendectomy were eligible for participation. Our primary outcome was length of time to resume full activity. Secondary outcomes included patient and caregiver preference for physician-directed versus self-directed activity restrictions, patient and family satisfaction, and postoperative complications. At 4 to 6 weeks postoperatively, parents and guardians were asked to complete a survey at their follow-up appointment or online via email. 82 patients were eligible and elected to enroll in the trial. The majority of families selected self-directed activity restrictions. Of the patients who enrolled in the study, 55 completed the postoperative survey. 80% of those patients elected to enroll in self-directed activity restrictions. We completed an analysis using the data from the postoperative surveys. We found that patients who enrolled in self-directed activity restrictions resumed full activity around 10 days after their procedure, while those who enrolled in physician-directed activity restrictions resumed full activity in approximately 12 days. However, this did not meet statistical significance. We found that the majority of patients and caregivers in both groups reported being very satisfied, and we did not observe any difference in satisfaction between physician-directed and self-directed activity restrictions. Postoperative complications were rare in each group, and there was no difference between groups. While there was no statistically significant difference in time to resume full activity, the results may be clinically significant. Decreased time to full activity may contribute to greater well-being for the patient and their family, as there is an apparent psychosocial benefit to liberalizing activity restrictions. Additionally, self-directed activity restrictions allow for greater patient and caregiver autonomy. A limitation of this study is that it was a non-randomized clinical trial and therefore was susceptible to selection bias. However, non-randomization enabled us to study patient and caregiver preference for activity restrictions. Additionally, the study was limited by our small sample size and the number of completed surveys. Our results may have been strengthened by a greater number of patients enrolled in surveys completed. Additionally, some of these numbers may have been decreased secondary to the COVID-19 pandemic, as many patients were not following up for their return appointments. In conclusion, we report that patients and their families overwhelmingly preferred self-directed to physician-directed activity restrictions. Therefore, we conclude that self-directed activity restrictions are a safe and beneficial option for children undergoing routine surgery. Future prospective studies should be completed to further analyze the clinical and psychosocial effects of activity restrictions on children and their families. Thank you for your time.